cc balloon will hold about 100 to 115 before it bursts. Okay? That's a 5 cc balloon. So a 30 cc balloon will hold like up to 200. So you often see that with us, when we do our TURPs, we often will have bleeding and we'll put traction. So we'll put a lot in the balloon, we'll pull it down, and that's usually when we do TURPs, we usually have a 3-way Foley, 30 cc balloon, we'll put like 50 or 60 in there, and then you pull back, and by pulling back, this area holds against the prostate and it stops bleeding. But you can put a fair amount, you can put 60 very easily in a 5 cc balloon without trouble. Now again, you guys shouldn't be doing that, but you can. So it's something, so yeah, it's not going to really pop on that. Now, the other reason we sometimes put big balloons in is sometimes you get people that have indwelling Foleys, and especially women. Women that have indwelling Foleys for a long time, their urethra will dilate. And they'll often have a patulous urethra that you can take your finger and put it in. And so on those patients, you need to have 30 or 40 or 50 in a balloon, and you can actually do it in a 5 cc balloon and get away with it. So it's something to realize that balloon holds a lot more than you think.
Why do we put the traction after lecture?
Yeah, well, why is what we said is that what happens is that the balloon kind of pulls back on the prostate. I'll show you in a minute. We have another picture. I think I have another picture of the urethra. But you use this thing to hold back on the basically at the bladder neck. You have a big bladder, and then you have the prostate. So prostate with the urethra in it, and then a big bladder. So if you put the catheter through, you have the balloon right here and you pull back. If there's bleeding coming right here at the neck and you're pulling back, the balloon is basically, holding pressure against that area, and so it's not going to bleed on you. So that's kind of what that's what you use for traction. So this area of the balloon is pulling against the prostate and stops the bleeding. So usually we have it on for, 2 hours, 3 hours, and then we say to release it. And we talked before already, any solution's okay if the catheter is only 48 hours, but water if it's greater than 24 hours. That's very important.
So when you guys do the TURPs and stuff, do you automatically put the water?
Yeah, so that's one of the things, for your point of view, when you're taking catheters out after a TURP, how much do you take out? Well, you keep sucking out until nothing else comes out, or you cut the port with a pair of scissors. The only problem with that, then you get a little water on your bed, but you'll often see me doing that, is that when I take a lot of catheters out, I'll just cut the port and you save the syringe because you have a pair of scissors with you. But if you don't, always, especially on TURPs, hook it up, suck it back. If you get 10 back, don't suddenly say, okay, that's it, and start pulling the catheter. Just keep sucking until you get nothing there, and double check, because you're going to have anywhere usually between about 20 and about 60 cc's in that balloon. Okay? So lubricant. This is another thing that's kind of can help you. You've all seen these little tubes that have the lidocaine jelly, and the little things like this that have lidocaine jelly. And everybody thinks those things are just wonderful. They're great. They just help catheters go in. The only reason those things help catheters go in is because we're injecting the jelly directly in the urethra. So with that same little syringe, you have the 2 syringes we talked about before that come with a kit, or the little thing like this that comes with a kit. The only thing you can't do it with is if you have the packet. When you have that little thing, you can take that syringe, put it up to the urethra, and inject it in. And often you'll see me, if you ever see me put a catheter in up here when you guys have failed, I'll come up and the first thing I'll do is I'll take that little syringe and I'll inject it in. If I had lidocaine jelly, I would use it just because maybe it helps a little, but you really have to keep the lidocaine jelly in for about 10 minutes before it's going to help. And the reality, all you're doing is you're just putting pressure there and you're blowing that urethra open with the jelly, and then you're putting things through. And when you use jelly, or if you use the regular lubricant that comes in the kit and you blow it in, the problem you're going to have is once you get the catheter in, it's not going to empty. And so it's probably going to be clogged with the jelly. So you either have to pull back with a syringe like this, or you can take the same syringe, hook it up to the end of the catheter, and create a seal and just pull back. With a little 10 cc syringe, you'll be able to get enough pressure sucking back to unclog it, if it's just clogged by the jelly. Okay? The other thing is get the patient comfortable. So if the guy has a big, huge bladder, if you look here, he's got a 4-liter bladder. Get them comfortable. If you have them kind of sitting, it's going to be tougher because there's more of a bend. If you have them laying flat with a pillow underneath his head, it's going to be better. Now the other thing when you're putting catheters in to be sure about, what do guys always want to do when you're screwing around with their penis? What do they do with their head when you're down there putting a catheter in? Well, most guys look down to see what are you doing, right? So when they put their head up, what happens? Pull your head up, you're tightening your muscles, you're tightening your stomach muscles, you're tightening your sphincter muscle. So if the whole time you're putting that catheter and that guy's sitting there looking at you, what are you doing to my penis? That's what's going on. So get the guy to put his head back, say put your head back, relax and breathe. Don't let the guy look, don't let him stare, keep him down, okay? Get in a position of comfort for the patient and for you, because that neck's tight, the belly's tight, and the sphincter's tight down here. The other thing that'll help you if you have a really fat guy. With a fat guy, they always have a big belly that kind of pushes over. Now the picture of that, you can put the bed down in Trendelenburg, which will get that penis out of the way, and it'll help things a little bit. So that if they're breathing, will allow it. So, good position. For women, same kind of thing. Make sure either you have stirrups, get their legs up, get two people holding their legs, especially if they're big. Get a light. If you're not sure where things are, you can always get a speculum or something to hold things around. But get assistance or get two people with fingers helping on the labia. So, remember, never blow up a balloon until you get flow or until it's hugged. When I mean hugged, you put the catheter in all the way, and then you pull back. Now again, if you have to force it to get it in all the way, be careful on that. But if you're, usually with a big full bladder, if you're putting a catheter in, that catheter's going to go in, it'll curl, and you'll be able to fit the whole catheter in all the way up. If you have this much hanging out from the penis, you're probably going to be in trouble if you're blowing up that balloon. You can blow it up in the prostate real easily. So, never blow up the balloon until it's hugged. Push on the bladder or aspirate on the catheter. And then once you do blow up the balloon, I always then kind of pull back on the catheter, and you'll feel it kind of snug in there. And that's kind of what that sponge traction is. You're pulling back on the prostate. You don't have to pull real tight, but you'll just feel it. You'll have this much leeway, and it'll catch. And you go, okay, yeah, it is there. That's where it is. And that gives you your feeling of success. There you go. So this, don't pay attention to. So a big thing is to know your limitations. So if you're not good at putting in catheters, and you do it one time, it doesn't work, and you're flustered, and the patient's flustered, get somebody to help you. And get somebody that has success, and they'll know. If a doctor tells you, use a caudative catheter, you've never used a caudative catheter, you don't know what a caudative catheter is, get somebody that does and get somebody that knows it. Because a caudative catheter is going to have the bend in it, and if you don't keep that bend up the whole time, it makes it worthless and even harder. So that's kind of what you have to know what you're doing. So these pictures kind of show up. This is prolapse, where the bladder's kind of coming out on a woman. So if you look here, here's a little prolapse, here's a big prolapse. And then here's a picture of big prolapse coming out. The whole bladder's coming out. But again, where's the urethra? Boom, right at the top of the labia where it's supposed to be. Clitoris is right here. The labia are kind of pushed aside. Bladder's here, but the urethra's there. So if you put the catheter in that area, it's going to go in. If you could also push your finger right against this area to invert that a little bit and then put it in, it'll go in too. So if you have trouble getting it in, just kind of push against that area gently. It's not going to hurt. She really doesn't have feeling there. Push it in a little bit and then put the catheter in and it'll slide right in. So know your anatomy. This is where the urethra is, always in a woman. Another picture, here's the cervix coming in. The whole vagina is inverted, but again, the urethra is going to be right here. Here's the labia, there's the clitoris, boom, there's the urethra. Same kind of thing, and it's going to slide right in, even though everything else is pushing out. You don't have to push that all the way in to get it in. If you're having trouble, you can just push it a little bit and the catheter will slip right in. Big people, this is what we talked about where you get into trouble. So again, stirrups, having people hold things up, putting them in Trendelenburg, a lot of things. Just make sure if you are going to put a patient in Trendelenburg, they can handle it on their lungs. Some of the big heavy people, if you put them in Trendelenburg, they can't breathe. You can take tape, you can have people hold the penis back, but you got to be able to get to that area. And then again, trust your anatomy. So hypospadias. Anybody know what hypospadias is? Right. When the urethra forms, when the bladder forms, it forms first. Everybody kind of forms the same. It forms like a giant cleft, and then it kind of closes over and closes over this whole way. So this whole urethra closes over and forms a tube, but it starts like a big groove. And when it's closing over, there's little areas where it can be left open. And instead of opening up at the pit where probably 95% of things go, it'll be somewhere along the line. So if you're ever putting a catheter in and you just put it in right there and it stops, and you're going, God, it should be going in. Why isn't that going in? Look down here. You might see something else, or ask the guy and say, have you ever had trouble with things in your penis? And they'll go, well, yeah, I pee out down here on my shaft, or my opening is down here by my scrotum. And often you'll see, because you'll have a funny foreskin called a glandular hood. Hypospadias never has the foreskin that goes all the way around. It kind of sits on here on the top like a hood, not on the bottom part. And that's what always happens. It's kind of called a glandular hood, kind of like a hood on a sweatshirt. You don't have it going all the way around where it closes off and you have kind of the turtleneck look. It's more of a hoodie. Okay? And again, we get fooled on this too. I have a guy that has hypospadias, and he has strictures because he's had a lot of operations, and you take him to the operating room, and I remember one of the first times I ever did him, you'd see him in the office, you knew what you were doing, you knew what the operation was. You get in there, you get your little dilators, and you say, wow, that's really tight, and you put it in, you went, wow, that's strange. Then you went, oh my gosh, idiot. And that's kind of what happens is you have to kind of know your anatomy, you know your patient. But if something looks funny, think about it for a minute, and rather than forcing, you start forcing in there, you're not going to get anything. Where if you get the right meatus, you're going to be okay. This guy has a big hydrocele, hernias, something pushing in, and the penis is kind of inverted. You can't really see here, but the penis is inverted here. The whole scrotum is pulled out, and he's kind of an inverted penis. So if this guy is laying down, he goes from standing up to laying down, then you start to see the penis. And if you push back on this area, then the glands will pop out. Same thing happens with really fat people. Fat guys get this big fat pad, and they all complain about having short penises as they get older. It's just that their fat pad here is pushing down, and although they'll have the same length on the penis, the fat pad pushes in, and it ends up giving them like, a 1-inch penis. And guys always, they're hung up on their penises just like, people are. So that's what happens, is that if you push on that area, things will expose, you'll have the glands. So retract and you get the inverted penis. It's also called a mangina. So this guy, same thing. This guy has a big hernia on the side. A hernia again is a hole up here. All the bowel is coming down, and he has a ton of bowel in his scrotum. And as it pulls down, it pulls on the penis and it inverts the penis. And this guy's the same way. This guy has a big hernia here, and the penis is kind of inverted. He also has an umbilical hernia, but the penis is inverted. He lays down, and you push on the area on the side. The mushroom of the glands will pop out, and then you'll be able to put the catheter in. You try to put it in with everything pushed down, you won't be able to. You got to push on the side a little bit. And the same thing with heavy guys. This is something you're going to have trouble with. It's called meatal stenosis. There's guys can get scarring that happens here naturally, and they end up with a little tiny opening, and you're going to have the hardest time getting a catheter through there. You can sometimes fit a feeding tube, you can sometimes dilate, but again, rarely will the nurses be expected to dilate. You shouldn't be. In those situations, either you have to have the doctors do it. We'll either sometimes put a hemostat in there and spread it, we'll take the sounds and spread it out, or there's other things we can do. Now, if you have a guy with phimosis, he's uncircumcised, and here again we're talking about the full foreskin. The guy with the hypospadias only has half of this, so it would only be covered over here, and then this area would be open, and the opening would be down here. But with this kind of situation, once you get through that area with a catheter, you're going to have the opening where it's supposed to be right down here. But you're going to have to get the catheter in partially, and then feel, and then get it in. And that's, a real common thing is you try to put it in, you get it through that area, and then it pushes back here and stops. Pushes down here and stops. It's kind of like when you're a kid, you used to drop clothespins in a milk bottle, at birthday parties. You have to get through the first opening and then find the second to get it in. So it's a little bit tougher. But that's what you have to do with a really tight phimosis. The other thing you can do is if you push the foreskin back, you can sometimes see the opening. But again, whenever you have a guy who's uncircumcised and you put the foreskin, push it back to get the catheter in, always put the foreskin back where it belongs. Leave the foreskin pulled back, it'll be like a tourniquet, the head of the penis will swell up, they got a lot of pain, and it'll be a lot of problems. So always replace the foreskin. Put the hood back once you're done. And again, big guys, as we were talking about before, putting them in Trendelenburg will really help. There's a guy over at Mercy that used to come in for a catheter about every 6 months, and he used to hate getting called because he'd struggle and struggle. And one of the nurses actually one time said, well, why don't you put his head down? And we were like, God, that's such a smart idea. Yeah. And so you put the head down, the belly goes away, all of a sudden you see a penis. Instead of having 3 people holding and pulling on this, this is like, he had like, 200 pounds down here. Instead of pulling on that, you let the gravity do it. One person put a hand there, there's the penis, and you can slip the catheter right in. The other thing is masking down, because it can be gross underneath there. So when guys get erections when you're putting catheters in, first thing is everybody gets embarrassed. You kind of, oh my gosh, and if you're a guy and you're putting a catheter in and a guy gets an erection, then you're really embarrassed. And so it's one of those things that if you're putting a catheter in a guy who has an erection, then you really have that right angle. And on top of that, if the penis is engorged, your urethra is going to be smaller. So it's a lot harder to get in. So often if you just kind of say, look, wait, I'll come back and I'll try it later. There's also medicine that we can give a little shot in the penis that will knock the erection down. So putting a catheter in an erect penis is really tough. Probably should try not to do it if you can. Strictures, we talked before about urethra. Instead of being a nice wide open area, you have strictures. Now certain strictures like this one, little valves, if you put a catheter through it, you can probably push it and get through, especially if you're spinning. Little ones like this is like an iris stricture. It's like an iris of the eye. It's a little tiny stricture on both sides. And if it's real skinny, if it's narrow, the catheter will pop through and blow through that, especially if you're spinning. If you get a real thick stricture like that or something like this, it's going to be real tough to do unless you dilate it up. And you might dilate it with a smaller catheter and get through, but that's kind of what's going to happen. You either need a real small catheter or you have to dilate it before you get in, because that's tough scar tissue. Okay, and for urology, usually when you call us, we'll come in, and we all think we're Supermen, but really a lot of us don't know what we're doing sometimes. So, with a catheter, like we talked about before, in a cudative catheter, this is the correct positioning. The tip of the catheter, the part that's going up, the ski part, is always the same part that has the balloon port and this little knob. You're always going to have it. So whenever you look at any cudative catheter, whether it's red, whether it's brown, it always has that little knob, it always has the balloon port, and those are where the ski tip is. And the whole reason we're using this thing is that usually when you went to put that catheter in, it's gone behind, so there's a hole behind. So if you use a little ski tip, it's going to go right in and slide right up. So this tip, if you keep it up, you're going to be good. So as you're sliding it in, it's going to go up. So this is the one catheter you don't want to twist. Remember I talked about spinning and twisting?
Yeah.
Don't do it with this one. This one you want it like a ski. You want it to go straight in, straight up. And it goes right up that curve that we talked about before, and we showed before in that right angle. It just makes it easier. We also have these little kits that we put in. It puts a little wire. The wire goes into the bladder, it goes through the tight area, and then we have these dilators, and then we dilate it up. Just like you dilate up a central line. The wire goes in first, and then this stuff goes on. We have these old things called filiforms and followers. Some of the older urologists still use them. I use them. Henderson probably uses them. McIntyre probably does. And you get this little long stiff thing, and you put it in, and it goes through the stricture, or it goes through the prostate, and then you screw this part on. And this little thing just keeps you in the right plane, and you just keep going back and forth, and it just kind of shows. If you get the little thing in first, and then you hook the other part up to it, it directs it into the bladder, and then you put your catheter in. these are the sounds, and again, this is